Better. welcome. I have two questions. My exam, as far as like the steps are concerned, because I was looking at a couple of the different ones, like on your notes. So like when you're heat fixing, are you making that as a step? Like, am I reading?
I won't ask about it that way.
Okay.
Yeah.
Okay.
Yeah. I would know. I mean, I don't think I asked about it. I don't remember every single question, even though, yeah, but yeah, I would know that like capsule doesn't have heat
No,
fixing. So I would just for sure that.
Like,
Right. Yeah. Yeah. Yeah.
I just wanted to make sure if that was a step or not. Okay.
Yeah. No, I won't ask about it like that.
Okay.
Feel like we are still lacking some people. It's so cold in here. My office is colder than this, you guys. It's the worst. I'm gonna have to turn on my space heater in there.
That's 2 weeks of stress.
So I'm gonna pass around the sign-in sheet. When I was like flipping it around to turn it to you guys' class, I took the little sign-in like pen, the little one, out, and I forgot to put it in before I brought it down here. So I'm putting a big marker in here. Just like put a line next to your name or something. Don't worry about like signing your name, okay? I can't be expected to really accomplish anything 100% this week. It's just gonna find a way to mess up something at every point. Anybody have any other questions before we get started? So I'll scan it into the Scantron machine as soon as you guys are done. Like I'll take it up to the machine and scan it, and then I have to hand enter it in. So if you guys were hanging out with a bunch of people and you see like one person's grade pop up, it's because I have to do each one individually. But and I know I can turn like the grades off where you can you don't see it, but I'm like, why? Because we're adults. I mean, you guys know what's happening. So yeah, I'm going to enter them in one by one once you guys are completely finished. And that's just you guys. So you will have it probably within 2 hours after taking the exam. Probably less than that, but I just want to give some leeway because there's been a lot of people trying to talk to me in the middle of me doing things today, well, all week. So I don't want to let anybody like sit there, oh, I'll have it 15 minutes done after the exam. And then, because that's usually my time frame. But yeah, it's been a weird week, you guys. Anybody else have any questions about anything? You guys know that you need number 2 pencils, yeah? If you don't have them, I have a few that you can borrow, but better to have your own. Before anybody gets like super depressed and thinking like, okay, you know, this test, I mean, of course, you guys know the types of questions I'm going to ask, but the average is 75. So that's better than the lecture exams. And my average in the past for my lab exams is lower than my lecture exams. And I mean that when I say in the past, I expect a 60 on the first lab exam. And you know what I think had a big, deal to do with it is those study sheets. I really do. Because it like made it easier for you guys to see the information in one place about that exercise and organize it then with nice colors. That actually helps me a lot. If I see like in a big outline, which is words and it's black and white, I'm just like, my brain is like, okay. So we need to divide this up somehow. Hope that helps you guys too. It's been no shit, even the online class did a 76. The in-person class did 75. Not that that's much of a difference, but yeah, so make sure you know the stuff, but don't expect it to be like the most harrowing exam in the world, because that's about where I would expect exam averages to be, is about that range, but ideally. Anything else anybody want to know about the test? Obviously it's just Scantron. There's not gonna be any drawing, or there's a couple of, I say, images, and of course there's slides, and there's like one plate, I think. So, and we'll go over like the details of it when we get up there, kind of the rules and all that stuff. But. Well, then I guess we'll get started with chapter 12. In case you haven't noticed, I figured this out. I figured it out with the night class, of course, after I had this whole big old tantrum about it with you guys. I just walked in here and just set it up perfectly with the night class. I'm like, okay, this is how this is gonna go. So yeah, so this is gonna work. So I can at least kind of walk you through this stuff. I have some of my notes. It's not as detailed as the other one. If you guys haven't looked through, like, you probably haven't, but the recording that I posted from my Monday, Wednesday class, I actually like walk through it like, okay, this is this information after this like first, meaningful slide. This is how I set it up. And then I go step by step on, okay, we made it through these slides. This is what I would have added after these slides. I can't do it obviously after every slide because that's just ridiculous, but that's how I had set it up. So if you are interested in seeing how I would go through and make my notes and what information I find important, that is helpful. I will also be giving you like summation slides with this one, so you'll kind of get an idea of how I would have set it up. When I was putting this one together, I started doing it at like 9:30 at night. No, it wasn't, because I was still at the late lab with them. It was 11 o'clock at night for this one. That I started on this one. So this is not as pretty and as organized as the other one is, because I had time to take, some time with it. So when I was going through, it probably actually more accurately mimics how you guys would be taking notes in lecture, because you're not thinking about, okay, how am I going to orient this with this when you're writing it down necessarily. So especially if you're writing on paper is really what I'm talking about. So yeah, so maybe that'll be better. I don't know. It's not as colorful, I will say that. Okay, so I'm just saying, but hopefully maybe seeing that, since you guys didn't get to see it in the last one, will make a little more sense. Because when you're taking notes, you definitely want to be focusing on what you need to know instead of all this other extraneous crap around it. And what I mean by that is, if you can look at the study sheet, and I highly recommend, if you, I'm not going to judge anybody that isn't doing this, but I recommend having the study sheet like with you if you're a paper note taker, or even computer, I guess, somehow having it with your notes at the same time, because otherwise you are likely writing down stuff that you think might be important, that is just stuff to help you understand something and isn't itself important. And so people will start studying it like it's important and be like, well, I don't understand what this process is, and then go look it up and whatever. Or like when they go have all those notes written down in their thing and they look at the slides and they aren't there in the lecture hearing me talk about the thing, then rewatching these freaking lectures over and over again, or reading the textbook, or whatever other useless thing you could be doing. And yes, I do mean useless when I say those things. If you guys are reading the whole text about these chapters, you are wasting your time. Straight up. Okay. If you are rewatching the lectures, the whole lectures, unless you missed that lecture, you are wasting your time. Because I guarantee you there's stuff in that lecture, you already knew it. You were there. There's plenty of it that you understand, right? When we go to talk about sterilization, do you guys really need to be watching a whole part of the lecture about that? Probably not, right? It's pretty easy to write down the note, kills everything. Do you need to go revisit that? So stuff like that is what I'm talking about. I guarantee you that what the problem is with almost all my students that are struggling, you are doing too much, too late. People try to cram the night before and you think that's good enough. And I'm sure you have realized that it is not. You wait until a couple days before the exam. You're not doing it right, guaranteed. If you make the notes for the chapter and they contain the information that you actually need to know based on what the study sheet tells you, and tick off those boxes. If you look at the study sheet and you tick off the boxes on this thing as you're going through it, like I have, like literally can't quite see it on this. It's, of course, this projector is really high quality, but yeah, just go along and make sure that, okay, yeah, I understand this whole sentence. Now this makes sense to you. You've written notes that have words that make that statement make sense. And if those two can tie together, and now both of what you wrote and what that says on that study sheet makes sense, mark it off. And you don't need anything beyond it for that topic. And once you have everything on here marked off like that, it should be that you would have all of your topics covered for that chapter, right? So that's the idea, because I will absolutely go over all of these in every lecture. None of this is left off. So go through, match up with what I'm talking about. With that, write down only what you need to understand what's on here. If you don't understand what I'm talking about, then circle it and come back to it later and figure out those difficult things. Yes. And after you've done that and added those into your notes, take those notes on the same day. Those notes that you wrote for chapter 11 or 12, whatever it is, afterwards, after you're done with lab or whatever, just take an hour tops to reorganize those notes like we had seen before, like in a way that makes sense. You see it, and now it makes sense to you what these topics are doing with one another and what things you need to know, all on one page. Especially if you're doing that and taking like an hour to do that, and it doesn't take very long if you made good notes and you understand what you just wrote down, which is the first step. That's the biggest step. Making sure you're writing down what you need to and understanding what you're writing down. Copying words off of a slide, copying words out of a textbook, copying words off of your notes or somebody else's notes, waste of time. If you don't understand what you're writing, why are you even writing it? You could easily just be writing like the script of Jurassic Park down and remember that just as well and do just as well on the test, probably. I'm just saying, it's a waste of your time. Don't just mindlessly copy words. If you're writing something down in your notes, y'all, you better understand what you're writing. If you don't understand it, put a question mark. Don't understand this. Circle it, come back to it later. Look it up in the text specifically. Sure, use the text then, but you don't need to read the whole damn thing. Or look it up in the recording later and see if you can make sense of it now that you've seen the whole chapter. Or ask a buddy, or ask ChatGPT. That's okay. As long as if ChatGPT gives you an answer and you look at your study guide and it makes sense, that's fine. Because sometimes it's full of crap. So use those resources. But if you're just doing that, taking meaningful notes relating to the study sheet, which you know that's the only stuff that's going to be on the exam. It'll be questions relating to understanding that material. Taking just that. And you guys know I'm right about this because you've taken the exam and you can look back at it and it's fine. But you guys are usually going in before the exam, maybe a couple days, if we're lucky, a week before the exam, but a couple days before the exam, a couple hours before the exam, and just trying to like cram in all this stuff. And you are doing it in the worst way possible. If I had to cram, guarantee nobody in this whole university as a student would be doing it the way that I would have done it and successfully done it. Because you guys don't even know what you're doing. You're just making it up or taking notes from people that also made it up. How like, yeah, no, I just write down, I just copy the notes. I'm sure that's going to help you understand the material, you know? So there's things that I do to cram if I have to. And that only includes working with a group of people, watching recorded lectures and making notes together and stopping every time somebody doesn't understand a thing and talking it out with each other. Because if you can talk it out with another person and understand it, guaranteed you can understand it on the exam. But if you're not cramming like that, and that takes work. If you're cramming as flashcards, if you're cramming as copying, if you're cramming as reading, if you're cramming as, oh my God, God forbid, Quizlets, you are not doing enough. And I mean, you're probably wasting your time is what I'm saying. That is usually the case. People spend, I spent 6 hours studying. Tell me exactly what you did. I bet I can parse out that you spent maybe 10 minutes studying in that 6 hours. And tell me I'm wrong. Do you guys really have any idea of what's effective for you to study and do well on exams? Or are you just kind of just doing what you've always done? Who knows what's the best, right? So focus on the things you need to know up front. I promise if you make good notes on these chapters now, Do your best to understand them right now, here. Take an hour after class to organize your notes. You know what I would do for the exam? If I had done that, okay, I got my study sheet together that has all the info for chapter 11. Now I've got all my ones, chapters 11, 12, 15, 16, 17, and 18. I've got all just 6 pages of info that I've consolidated onto those pages. The stuff that I need written on there to tell me about what's on the study sheets for those 6 chapters on these many pages of study sheet. Take that, go over it, make sure it still makes sense. If something doesn't, if a term, like let's say a term that we went over in chapter 11 and you're studying for the exam, doesn't make sense for you at that time, then make a flashcard as you go through that. You shouldn't have a stack of flashcards or a Quizlet, that's fine too. You shouldn't have this whole like Quizlets that you're relying on to get you through that chapter. When the Quizlets are only going to ask you that question about that thing. You need to understand the whole concept of the thing. Don't rely on it. And that's why people aren't getting as good a grades as they want to. Anyways, what I'm saying is you do this up front for this chapter and then do it again for the next chapter as you go while it's there in your mind and you can remember and reorganize it that way so that when you come see that sheet again, you remembered how those things related to one another and you can see your notes on there that make sense on that one sheet. Read through your 6 sheets, make flashcards on the terms that you didn't quite stick, and that should be it. That could be it. That's your studying for the exam, literally. Just go over those sheets. And I don't mean pour over them for hours and hours. Okay, I got this sheet down. Okay, let's come back to this sheet. No, if you understood it the first time you looked through it, y'all, you're not going to understand it better by staring at it over and over again, right? So this is the goal. Make yourself study sheets for each chapter while we're here in this topic. Make them useful to you for understanding these things that we're going over. Not a lot of it is super terrible. It's just a lot of info. So write about what you need to, a lot about what you need to, and very little about what you don't need to. Consolidate it, what works for you. Then when we have to come study, you can look over just those sheets, make flashcards over what you know. And then the best possible thing you could do after that, explain your sheets to somebody else. Say, okay, so this is my notes on chapter 11. Now, we talked about in chapter 11, the difference between sterilization and you have your sheet there to help you through, but you are reaffirming what's on your sheet and what you explained by explaining it out to somebody. If you guys are taking good notes and you're making your study sheet work for you, that stuff should just come out of your mouth because you've been working on it. Yeah, you don't need to come in front of people like in a group, but it, you know, some of you will be because you're going to do the presentation, but at least with a study partner and at the very, very least by yourself, just say it out loud. And this is not blowing smoke up people's asses. They like hear me say, okay, scientifically proven. If you say it out loud, you learn it better. And then nobody does it. And I'm like, what are you doing? I just told you all you have to do is say it out loud. Just explain it. So when I ask you guys questions in class about something like sterilization or disinfection, what is disinfection? Anybody here know what it means? Yes.
So it doesn't sterilize, it's just kind of safe.
Literally just doesn't sterilize. That's what it means. So if y'all are thinking beyond that or writing more than that, you're wasting your time, right? That's what it means. Disinfection, and usually on inanimate surfaces, but I'm not usually going to be that specific. If you can remember that, but also know that asepsis or antiseptics and things like that are used on skin, then you know they're a different thing because there's a different word for it. Even just things like that. Use deductive reasoning sometimes too. Don't be afraid of that. People seem terrified if they don't see the exact answer that they're looking for, that they can't look at the other ones somehow and like cross them off effectively. And yeah, so if you know the stuff well enough, make it easy enough for you. You don't need to be making it complicated. If you're telling me you studied for 6 hours the night before, I will automatically, you don't need to tell me what you did. I'll tell you that you did it wrong. Shouldn't be doing that. If you're like, well, I didn't study the whole time and I waited until, you know, the night before. I'm like, yep, I told you you did it wrong. I don't care what you did at that point. You did it wrong. You should have been studying the whole time. It's way easier on you. Guess how much less stressed you're going to be about that test if you already just knew it. You can just walk in, look at your sheets right before you take the test, sit down, saunter in and answer your questions and leave. Because you ain't worried about it because you didn't have to rely on what you studied 6 hours ago. And crammed in there. I'm not wrong. Right? How many of you guys have relied on, you don't have to raise your hand, but how many of you guys relied on cramming? probably almost every single one of you on almost every single test you've taken. I'm betting. It's super ineffective, especially if you don't know how to study. You already don't know how to study, and now you're going to do it just only 6 hours before the exam. Good luck. That's why our averages are so low. It's not because it's hard. Yes, it's hard because it's a lot of new information. But if you're also shit at studying, it's not going to make it easier. So this is why I'm going over this, okay? You do what you want to do. What works for you. If you think it really is working for you, don't let me stop you. But that's my recommendation on how you can do less and gain more. It means doing work up front. It doesn't mean you come in here and write down your notes and then go home and forget about it. Just reorganize them. You can reorganize them and then forget about it if you want to, but take that step to look through them again, because it's different, right? You're taking the notes while I'm talking and you're hearing that, maybe writing down the note about the thing, but when you're looking at the whole big picture and trying to like reorganize them and see what you need to make it work for you, that's a different thing, isn't it? So just take the time to do that, please. Try it once. In fact, if you don't think that it will work for you, I recommend, if you have not already done so, the Kahoot for chapter 11 or the quiz for chapter 11. Use my summary sheet, just that one sheet. I have like a few notes, right? But I have one at the bottom that is my summary sheet. Use that one sheet and see if it doesn't answer every question for you. And if it doesn't, it's probably because you weren't taking notes good in class for you even to understand my notes. But again, that's a different thing, isn't it? So try it. See if it makes sense to you. Look, or just look through the sheet and see if it makes sense to you, right? That's one place to start. Look through it, see if it makes sense to you. And that might be enough for you to be like, okay, now I'm convinced. If you can look at my study sheet and compare it to what we have on this study sheet, like my personal study sheet versus the actual printed out study sheet, which is just black and white BS, you can compare it to that and it makes sense to you, then you know that's something that can work for you. Wouldn't you rather just have one sheet of pared down information? You don't need a whole big explanation of what sterilization is, just it kills everything. You can write that in your notes. It doesn't have to be word for word what's on here. Does it matter? Can you not pick out the choice that also means kills everything on the test, right? Because if there's anything that says that involves not killing everything, that's not the answer. End of story. So you need to know how you guys would want to word those things. The best way to figure that out is by making the notes to make sense of what I'm talking about here in lecture. Let's just do it. Now I can keep saying it over and over again, but this was my sheet that I made for this chapter. All right. Okay, microbicidal is valued when we're looking at antibiotics or antimicrobials in general over microbistatic. I don't think that even needs anybody to say anything about that because duh, right? Wouldn't you rather have your antibiotic or your cleaning or whatever it is kill the bacteria than let it be surviving in the background? So we do want something that's going to kill our microbes. I'm going to come back to the first one, I promise. We want something that's going to work in a body and remain there long enough to do its job and not be secreted too early. And then excreted, I meant. And then we don't want any resistance to be developing if we can help it. Now, there's no perfect drug in the world, but that's the goal. But this top one, toxic to the microbe and non-toxic to the host. That might seem like some novel, thought, applying this to drugs that you could be taking. Okay, yeah, we want toxic to the microbe, but we don't want to harm the host. Nice way to be making it sound fancy when all we're saying is let's not have side effects when we kill these guys, right? That's all it's saying. We want to be killing these guys, but not harming the person taking them. And you'd be surprised how many of the drugs, antibiotics even specifically, that you've taken that are associated with pretty severe side effects. We'll talk about why that is today. So antimicrobial drugs, again, we want them to remain there and be delivered to the site easily and not disrupt host functions or cause allergies or anything like that. We say readily delivered to the site of infection. If you're going to take an oral antibiotic for a skin infection, you need to have your patient have good enough circulation to get that antibiotic to that skin area. Number one example of what you guys will see if you go do rounds at like ER or anything else in a hospital, treating patients that have infections that are difficult to treat. Almost always are they going to be diabetic because they have terrible circulation. And that makes it really difficult for drugs like antibiotics to get to the areas where the infections usually start or are progressing. So we have situations where people, all it takes is stubbing your toe. You know, you went outside and stepped on one of the stickers in the grass and it, poked in and you got a little bleeding. Well, bacteria got in there and you don't have good blood flow to that area. So your immune system can't help you out. So you go to the doctor because you get an infection. They give you an antibiotic, except you're diabetic and you don't have good enough flow to that area for the antibiotic to get there. And now suddenly you have a horrible necrotic infection where you will have to have your toe amputated. And if you get the toe amputated, you better hope that the antibiotics you're taking to prevent that wound, to close up your toe being amputated, you better hope those antibiotics are getting to where that is. Because otherwise you have an open wound that antibiotics aren't getting to. So anything that you're exposed to in the entire environment is getting into that wound and not being prevented from growing by your immune system or your antibiotic. And that is why we see diabetes being so progressively aggressive like this. Why, when I worked at Southwest, we would have multiple feet and legs a day brought to us for pathology. This is not a joke, and it is very serious, and will lead to people losing their lives. So when we talk about choosing antibiotics that have to be delivered to the site of infection, I want you to think about that example. We're not talking about, treating your acne here. We're talking about people can die if we don't treat this. You might say, put it on topically then on the surface. Okay, but then what about the microbes that are deeper in the tissues? Because that only works on the surface. So what do you do? And then the fact of the matter is you have to amputate. Even still today, that's usually the best option. And it's sad, but it is the truth. Until you can get to a point where you can control the infections. And sometimes it just doesn't work out. All right, so next, antimicrobial terminology. So prophylaxis, I know you guys may have heard of this. They talk about, condoms being prophylactic or birth control pills being prophylactic or whatever. It just means you're preventing the thing, okay? So prophylaxis, just trying to prevent infection or, having a baby or whatever it is. In this case, you can take antibiotics ahead of time before you go into your surgery to have your hip replaced. And this is the most common thing if you're going to have a joint replacement. They'll start you on antibiotics beforehand so that you don't develop a biofilm from any bacteria that could have somehow made it through this surgery, right? So we have that. Antimicrobial chemotherapy is just a fancy word for drugs that kill germs. Okay, if you guys hear antimicrobial, of course that makes sense. Antimicrobes, microbes are just germs, that's fine. Chemotherapy does not mean treating cancer. And if you did think that, now you learned a thing. It does not mean treating cancer. It means anytime you use a chemical to treat somebody for anything, it's chemotherapy, right? So now you're getting treatment for your cancer and they're like, okay, well, we're going to start you on chemotherapy. Chemotherapy is the part of cancer treatment that isn't radiation, essentially. If you're taking chemicals to treat it, radiation is not chemotherapy, right? We've already learned that it's not chemicals, it's using energy to disrupt the cells. So now you guys know how radiation works. You can understand if radiation could cause damage to the DNA and lead to cancer, it could also cause damage to the cancer's DNA and stop it from being cancer. It's dangerous too, though, right?
Why is there a lot of misinformation around that?
What do you mean?
Like a lot of people don't understand that.
Everybody just always hears chemotherapy in the context of cancer. It doesn't occur to them that it also just means drug therapy, like it just means chemical therapy. I just think if people haven't thought about it that way, because we don't talk about it as like antimicrobial chemotherapy. You might if you go into pharmaceuticals, but so that's probably a term like if you guys go into dealing more with pharmaceuticals in nursing, if that's what your profession is going to be, talking about it as chemotherapy more. But yeah, all right, antimicrobials is an all-inclusive term for all microbes. That's an easy one. And then antibiotics is a term we use for bacteria only. Okay, we treat only bacteria with antibiotics. So wait, I remember that. I know antibiotic sounds like, okay, biotic, that's, okay, what would that be? Just think of the B as for bacteria. B for bacteria on that one. All right, so we know some of these guys can come from natural sources. If you've heard of penicillin, you probably know the story of it being like moldy bread, and then they discovered that microbes wouldn't grow near like mold on petri dishes and everything like that. And then we were able to extract the drug penicillin from that. But semi-synthetic drugs will be when we modify things that came from nature to make them work better. Synthetic drugs are things that we make from scratch, that we have knowledge about how antibiotics work. And so we just design them. They're designer drugs. Narrow spectrum, obviously, we're only treating a few things. It might just be only gram-positive bacteria, whereas broad spectrum could be like all bacteria or all vegetative cells, right? Those kind of speak for themselves. So let's see, common metabolic. Oh yeah, so antibiotics in general, they are made by bacteria and fungi. So even though bacteria are treated with antibiotics, definitely not every bacteria is susceptible to every antibiotic, right? And sometimes that's because that bacteria makes this antibiotic to keep the other guys from growing anywhere near it. That's practically not uncommon. So we will see that happening. In the fungi, that just makes sense. You want to keep the bacteria away from you. So these guys make these chemicals to keep themselves safe in their own environments. We already talked about these, so I'm not going to go over it anymore, but semi-synthetic, just making drugs that exist already more effective by adding on functional groups. And then synthetic, they are designer drugs, but oftentimes the designer drugs are not very good at permeating the membrane, crossing the membrane, because I don't know, they're just not good at designing it that way or something. I get it. All right, let's say you have a patient that comes in with an infection. What do? You need to identify the microbe. That should be one of your main, steps involved here. You don't just treat, oh, bacteria, here is antibiotic. But what is the microbe? That's the best way to approach it, because now you can get specific and know where you're going with this, and other people can learn from your experience later on through case studies and things. So identify the microbe. Then we're going to determine the degree of that microbe's sensitivity to the drug. I wonder how we're going to do that. Not going to be familiar at all, I'm sure. And then the overall medical condition of the patient. So can that patient handle taking that drug, for example? Because they've already got problems, they might not be able to. You want to do that identification step before you ever give any drugs, if you can, if you're capable. If somebody comes in with a serious infection like sepsis, if you're septic and you have, microbes growing in your bloodstream, like bacteria typically, you can go south very quickly. And so you want to start probably treating somebody with kind of broad spectrum, couple of antibiotics at first until you can determine what the microbe is. And then you can just be more specific with it, but you want to get something to them. That's definitely the case with meningitis, which can start, causing so much damage that it can start causing permanent brain damage if you don't treat it quickly, even death. So yeah, oh man, look at that. Kirby Bauer. Y'all, told you it was a real thing. So Kirby Bauer is one of the best things that we have available to determine antibacterial susceptibility. It just is. And so that's why we learn about it in the lab. You form that zone of inhibition where you don't have growth around the disc of antibiotic. And you can determine, build an antibiogram, which is just what antibiotics your microbe is susceptible to and basically which ones are most effective. Okay, so our ZOA, we would measure it across the entire way across in millimeters. We already know this, it's going to be that blank area. There's also another thing that we can do, which is the E-test, which is very similar. So imagine that this strip that's on here, and it's hard to see it on this crappy projector, but the strip that's on here on the auger has different concentrations of the antibiotic all the way through it. And so you can put it down, and obviously at the top parts, we have our widest distribution away from that area, which is out here. And I followed the curve with that outside line there. And as you get further down, it's closer. As you get further down, it's closer. So what does that mean? That means down at the bottom, we have a less strong concentration, right? So the higher concentration at the top, of course, you're going to be more susceptible to the higher concentration than the lower concentration. This is exactly what actually happens in your regular zone of inhibition situation. It's just that we aren't seeing it patterning that way because we're putting one concentration down. And as you go away from it, it's less and less and less and less and less. So this is just showing you literally the concentration. So you can say down there at the bottom where that arrow points at, that is the minimum concentration of that antibiotic that you need to inhibit. It's the same number that you would reach at if you did the math for the edges of that ZOI. That's where that minimum concentration is that still inhibits. It's the same. But that just gives you a picture of it on those strips. So those are pretty useful if you're trying to determine helpful concentrations for your patient. And that, of course, minimum concentration that is able to still inhibit is called the MIC, the minimum inhibitory concentration. Yes. So it's the smallest amount you need to be effective. You want to choose the smallest amount you need to be effective because you want to avoid having any side effects. So let's say you do this, you do your Kirby Bauer, and you find out, okay, we did the swab of our patient, we put it on our plate, we put our stamps or our strip, whatever it is, and then we grew it. And this antibiotic is most effective, and it seems like it's going to be safe at this lower concentration. Great, let's do it. You give it to the patient and they don't get better. So what's the reasons for that? These are the possible reasons for that. I can't even see what this is. Let me pull this up over here. My mic went out. It should be on. Did I not have it on? I'm like worried about it. Hold on. Make sure it says it is. I probably just leaned on it or something. Anyways. I don't know. Can you hear it? Okay. Oh, right. Glad that that worked out. So anyways, I just saw that. My bad. So we have, I'm actually going to leave this up here so I can see your messages from now on. Right. Inability of it to diffuse to that body part. Exactly what we were talking about with our diabetic patients. Can't get to that area like of skin or the extremities. Or we have resistant microbes that we didn't happen to pick up on our swab of the area, let's say. Or we have more than one pathogen that we didn't see grow. We only saw one growing. And when we made that mistake, we didn't know that there was another one there that was resistant, for example. So those are the reasons why it would fail. There aren't other ones. That's just it. All right, so therapeutic index, that brings us to this. So we're trying to look, we now know our minimum inhibitory concentration. We want to aim for that region. If we can, less is, if it's still effective, use less. That's what I'm saying. So this therapeutic index, though, uses that to ask us the question of how can we avoid it now being toxic? So imagine that's your minimum inhibitory concentration of 0.5, whatever, that is going to be something that is around the same, about 0.5 is also what causes toxic effects in people. So start seeing, kidney damage and things like that. You might not want to use that drug if that's, going to be the case, because if that's the minimum amount that you would be able to give, and that person's going to be potentially having severe side effects at that concentration, that's a problem. So that's therapeutic index. We are looking at the toxic amount. So what concentration is toxic versus what concentration will be effective. And the closer that they are to one another, just like the 0.5 and the 0.5, that's bad. So we want ones that are much farther apart if we can help it. Avoid that toxicity. And that gets us back to that selective toxicity concept we said in the beginning of kill the bad guy, but don't harm the host, right? We want to make that as true as possible in our situations. So we could have also patients might have pre-existing medical conditions, allergies to the drug, underlying liver and kidney disease, or we have to also think about the infants, elderly and pregnant women, which might not be able to metabolize the drugs the same, or it might harm the fetus, or they have less appropriate immune responses and things like that, which should be helping out, and they just aren't. So those are all things we need to consider, but especially when we talk about liver and kidney disease, why that specifically? We did not put on this list heart disease, did we? We didn't even really put on here, that would just be in pre-existing medical conditions. Pop it up in there, diabetes, pre-existing medical conditions, whatever. But we specifically state underlying liver and kidney disease. So why would that be important? Because your liver is going to process all of your drugs for you. Anytime you even take freaking ibuprofen, that is going to go be processed by your liver. And no big deal if you're taking acetaminophen and ibuprofen, stuff that's over the counter, it's relatively tame. I mean, the amount of acetaminophen you would need to actually be toxic to your body, you probably would be the whole like 500 giant bottle of that. So it's pretty tame and your liver recovers. It bounces back really easily. But if you have cirrhosis or something like that, you might not be able to metabolize the drug as well. So it can cause more liver disease. On top of that, we have your kidneys. And your kidneys just need to be, your kidneys are pretty delicate, actually. They're going to be filtering out all of the drug at the end, a lot of the drugs anyways. So if they're getting damaged by this drug and it's causing the kidney to get, to have its function impeded by the damage that the drug is causing potentially, now other things that are supposed to be filtered out by the kidney aren't being filtered out properly and are building up as toxins in your blood. And you can see how it can become a cascade effect. If your kidney function starts lowering, it very quickly, the toxins that are building up because your kidneys aren't clearing them up will be just causing more damage. And then more toxins build up and they cause more damage. And that is why you can see kidney failure happen very quickly, like within hours, depending on the circumstance, but you can. So you don't want to touch those if you can help it. If this person already has those things going on, you want to be sure you're giving them drugs that aren't going to exacerbate those if you can help it. Sometimes you don't have a choice, right? Sometimes they have some disease that's completely resistant to everything else in your arsenal. So you have to give them this antibiotic to save their life. You're just going to have to put them on dialysis. That's just how it goes. You want to die or be on dialysis and maybe go up for a kidney transplant later. Your chances are better in that situation. So that's things that we need to think about. So these are some of these really pretty serious conversations to be thinking about. All right. Even though we go through all of that, you can still have drugs that could interact with other drugs a patient. Man, how bad are people about telling doctors about what drugs they're on? Like the worst. Like you'll go to the doctor, even me, I'm not going to lie. Like they'll be like, okay, these are the drugs you're on. I'm like, yeah. I'm thinking back in my mind, like I also take this vitamin and this vitamin and this vitamin and this. I take a lot of vitamins. Okay. So, but they're not all on my list. But what if one of these drugs, they could actually be affected by things that's just as stupid as a vitamin? And it's the truth. So yeah, it's pretty important that we need to have that upfront so that we can be aware of that. Our biome could be affected by our antibiotics as well. Duh. We've already talked about that a little bit, but you want to keep, you want to avoid having to ruin the biome if you can help that too, because we need it there. Our microbial antagonism, where our good guys take up the stadium seats so the bad guys can't sit down. That's what that is. All right, so that selective toxicity, this is what we talked about at the very, very first slide, where we said, you know, you want to kill the bad guys and not harm the person. So be toxic to the microbes, but non-toxic to the person taking it. That's the goal. And so we have to consider all these other factors that we talked about, as well as the therapeutic index, the concentration versus the toxicity levels, all of these things. So we want to also choose drugs preferentially that target aspects of microbes that we do not share with them, which seems simple enough because they're bacteria and we're eukaryotes, but it's not actually as simple as that. But penicillins, what they do is they block the synthesis of the cell wall, the peptidoglycan cell wall of bacteria. Now we know we don't have that in our cells, in our own cells. So that's a pretty good drug to be leaning towards, right? It's a very safe thing. It's not going to affect our cells directly. Let's go for that. Let's block the cell wall from that. We'll come back to it. It's not all that easy, right? So you can affect the cell wall, like we just mentioned, or nucleic acids, or proteins, or membranes, right? We went over all this in chapter 11 for that stuff too. We have one more thing added on here, and it's going to be folic acid synthesis. We do not make our own folic acid. We get it from our diet. It's a growth factor, like a vitamin is. So we have to have it supplied to us in our diet. It's why whenever you're pregnant, they'll give you like folate pills and stuff, or recommend that you be on folate, because you aren't going to get enough from your diet if you're growing a whole person inside of you. So, but we don't make ours. Bacteria do. So, hey, we've got cell wall, and we can target the pathway of making folic acid because that doesn't affect us. So we've got two really good targets here so far. All right, so this is a good chart to come back to when you're studying. You only need to know the ones that are on the study sheet, by the way. So there's extra ones on the chart. I didn't make this, but I would definitely be aware of one of the things that I'll ask a lot on these is like, okay, penicillin, what part of the bacteria does that affect? And I'll have a list of all the parts, and you'd have to tell me penicillin affects the cell wall, for example. That's a common one. Or maybe I'd say, which of the following affect the cell wall? And one of the choices would be penicillin, and maybe there's other ones on there too, and you have to pick it out. So that's pretty common ones. I'm not going to ask you a lot of the stuff that's on in the textbook. I'm just saying I don't want you to have to know everything about these antibiotics. All right, so what side effects we can see? These are going to be damage within a person, the tissues, whatever. We could have allergy developing, or we could have disruption of the microbiome. So these are problems we can see with those. The drugs themselves can act as antigens. We already know that those are things that we see as, that our immune system can react against, right? So that's what that is. So drugs can be that. It doesn't always have to be proteins. It can be literally any molecule ever that your body can see as foreign and create a response against it. So drugs, and sometimes you're reacting to the drug up front that you're taking, or things that are like intermediates that your body like broke it down to this or whatever, and that's what you're allergic to. But it doesn't really help you much either way, right? Because if you're allergic, you're allergic. You can be like seriously deadly allergic. We're talking anaphylactic shock kind of situation. So penicillin, are cell wall drugs. And sulfonamides or sulfas, that, by the way, those are our folic acid synthesis targeting drugs. Yeah, so those are the two most common ones. Penicillin by far the most common, and then sulfas after that. That limits our choice on what we can treat you with if you're allergic to psyllins or if you're allergic to sulfas. Well, you'll die. That's why. So I think it has something to do, the psyllins, it has something to do with when your body is already reacting to something else in your body, and it has this inflammatory response going, and then it also sees penicillin or something like that. And it's like, oh, you're also in this, and you're also weird and foreign, and then it is more likely to have a response. It just has something to do with the structure of the drug more than anything. Yeah. Yeah, and why not other drugs? And I don't have an answer for that, really. All right, so yeah, we already know if you give somebody antibiotics for their urinary tract infection, and that clears out their whole microbiome in their genital area, that they're likely to get a yeast infection, because antibiotics don't kill yeast. So we've cleared out the whole stadium, but the yeast are still sitting there being like, I got this whole place to myself, and they overgrow, right? Simple concept. That is called superinfection. Same thing what we see with C. diff. If you put someone on antibiotics in a hospital, kill off their whole biome in their gut. If they have just a few C. diff, and it's normal to have a few, but it'll overgrow and cause problems because of those endospores. Don't we love it? My mom, I went to go see her this last weekend in Tulsa, and she was telling me she has gut issues, and she's been dealing with diverticulitis. And she was telling me about the drugs that they had put her on recently, because she's having like some really bad problems with like just everything working how it's supposed to. And if you don't know, diverticulitis is where you get like inflammation in the gut, and then you develop like these pockets in the gut, and that will like house bacteria essentially. It's like almost like they individually become little pus-filled pockets, and it's just a ton of inflammation, and it can cause a lot of issues with that. And so you can't have certain foods that'll get stuck in the little pockets that you've developed and whatever. So you don't know, then look into it, because it's actually a very common thing, especially as you get older. And I think it's actually, I don't know why, but I think it might actually be more common in women, but I don't know why that would be, but I just think it is. I might be wrong about that though. Anyways, antibiotics only treat bacteria. We talked selective toxicity. You want to kill microbes without hurting the patient. Therapeutic index, toxic versus effective doses, right? Superinfection, killing off the good guys. And then Kirby-Bauer assay, zone of inhibition versus the minimum inhibitory concentration. I have my little explanations of those if I needed them, but that's what I made notes of for that whole part above me. Okay. Y'all had a whole bunch of stuff up there, and that's what I pulled out of it. Maybe you had other things that you might want to explain more, but if you're explaining things that aren't on the study sheet, don't bother. Okay. Just use them as like, some of that stuff is on there as supplement to help you understand the main points. So look at it that way. Right, antibiotics can be broad spectrum, or they can be narrow spectrum, and this kind of shows that. Look at tetracyclines, man. gram negative, gram positive, chlamydias, rickettsias, all can be treated by tetracyclines. Pretty impressive. Whenever you look up there at whatever tobramycin and polymyxin are, the little purple and blue up near the top, man, those are not quite as useful. They're in the mycobacteria area and not even the whole thing. All right, so let's get into the cell wall, guys. We already introduced the penicillin group. So all the cillins and pretty much everybody in the cell wall category, these guys are beta lactams. But the first group being in our original, the OGs, the penicillins. And we know that. So anything psyllin falls into this category if it has psyllin at the end of it. The most important part, and like you guys can see all these pictures, and it's like, oh, it consists of these parts, whatever. Don't care. Beta lactam ring, not going to show you a picture of it or make you draw it. Just know that that is what is going to define a lot of these cell wall guys. Okay.
Part of the acid test.
Yes. I'm glad you remembered that. It may or may not be on the lab exam, just saying. Okay. Cephalosporins and carbapenems. I'm not going to ask you too much about them. If you notice on the study sheet, you'll just have like a list of some antibiotics and not have any more explanations. Guess what? You don't need to know any more about them other than they affect the cell wall. But I will tell you this about carbapenems. You don't know that you do need to know that cephalosporins and carbapenems affect the cell wall, but you don't need to know anything else about them. But it's useful to understand carbapenem. It is a last line defense antibiotic. If I'm giving you carbapenem, you're screwed. You went through the ringer, man, because this is the last one they're going to reach for over almost any drug ever. This is one of the last ones. It's not that it's so much toxic, but it's like it is very effective. It is somewhat toxic, but they don't see a lot of resistance in it, and they don't want to have resistance in it. So they're trying to.
It's really bad on your kidneys.
Yes, it's pretty bad on the kidneys. A lot of the ones that they leave for like the end, things like vancomycin and worse, up to carbapenem, they're all pretty bad on your kidneys. Yeah, they can be pretty bad. Like actually, like if you're elderly and your kidneys are otherwise fine, you can see severe kidney damage from taking some of these drugs. Yeah.
Let's say that's what they were going to give my son at one point. They couldn't diagnose what he had.
And they just wanted to give something that would like.
And they said he would be on dialysis if they gave him this drug.
Yeah.
It would ultimately
Treat it. Yeah. Did they give it?
No.
Okay, good.
They figured out meningitis.
Okay. So they just treated that specifically. Yeah. It happens. Unfortunately. Don't we wish that it all followed the rules that we learned? It would be great. But yeah, carbapenems are a bad deal. You don't want to be on them. I'll say this too. You don't need to know these guys, but bacitracin, that's one of them in Neosporin, like triple antibiotic creams. Okay. Neosporin has bacitracin, neomycin, and polymyxin, which is one we saw just a second ago. Isoniazid is used to treat tuberculosis, and then vancomycin. Vancomycin is like one of the only mycins that don't fall into the category where they usually belong, but I'm not going to test you over it, so you don't need to worry about it. Okay. So here's my little makeup board. I'm going to go through and make a little chart of these guys. That's all you need to know about them. Turns out penicillins, what do they affect? Cell wall. If it has a beta lactam ring, what does it have to do with treating the cell wall? So, all right, we have protein synthesis. The big group, there's two groups that fall into this, the aminoglycosides and the macrolides, okay? The aminoglycosides, they're pretty broad spectrum. They came from organisms originally, and then we like modify them and whatever. Most of them inhibit the ribosome. So protein synthesis, but by inhibiting the ribosome. So we can't actually make the protein because the machine is gummed up, right? So you stop the ribosome, you stop translation, and I drew you guys a little chart there to remind you guys of where we're making this stop happen in the cell process. My nose is so, when I talk a lot, the nose ring just tickles like nose hairs or something. So I know more information that you wanted to know, but it's just killing me right now. Yes, we'll talk about transcription later though. So look at this circle that I drew over here. This is what we're going to be talking about are those guys. I know you can't quite read it, but hey, it's the next slide. These are the tetracyclines. So affects ribosome function. It is an aminoglycoside. Yeah, blocks ribosomes. I don't know what else to say. It's pretty broad spectrum, and it has pretty serious side effects. If you're on tetracycline for any considerable amount of time, it can give you these like weird gray bands that are very visible on your teeth. It's weird. You don't want to take it, but because they're so broad spectrum, it can be kind of a dangerous thing. The macrolides, you just need to know they affect protein synthesis. Good job. Okay. A lot of these guys are the mycins. So when I said vancomycin, it does the cell wall. Everybody else does this. And I'm not going to ask you about vancomycin. Just worry about mycins or macrolides. They affect protein synthesis. Fair? That's it. If you're interested about more info, it is on that slide, but it's not going to be tested over it. Sulfa drugs. These are the ones that affect the folic acid synthesis pathway that we don't have. These are almost all of them competitive or non-competitive inhibitors to enzymes in that pathway leading up to making folic acid. This includes oh my God, this is the one I cannot say. Sulfasoxazole, did it, okay? Don't make me do it again. That is going to be good for UTIs and some certain protozoan infections. We're not going to see it pop up again in the protozoa, but I'm not going to ask you about it in that context. If it has sulf in it somewhere, we have sulfasoxazole, I have to say it slow, or sulfadiazine or sulfamethoxazole. I don't know why that one's easier for me, but it is. And those are all sulfa. Sulfa anything, folic acid synthesis. We also have trimethoprim, which is the one that doesn't have sulfa in it, but it still falls into folic acid inhibitor pathway, and it's usually working in tandem with the others. So that's the one that you'll have to remember as the outlier. But the metho, to me, like if I think of metho, I think of like methane, and methane stinks, and so does anything with sulfur in it. And so those stinky guys will go into, that's how I remember it, the folic acid pathway. Okay, next we're going on to the quinolones. These are the ones that are going to attack DNA and RNA synthesis. So now we're talking about replication or transcription. Most of these are fluoroquinolones specifically. This is the term that you need to know, fluoroquinolones, okay? These guys work to inhibit helicase, which don't need to remember that. I'm not going to test you over, but it does inhibit the unwinding of DNA because you have to unwind it in order to separate it and start making copies of whatever. So it prevents that. So these are pretty high potency and broad spectrum, readily absorbed in the intestine. Sounds great. Yes, we're going to start killing things. Good. Stop their DNA and transcription. Turns out you also have DNA and transcription. Like you also need to do those things. Yes. Helicase? Yes. Yeah. So this can be pretty toxic to people. It can cause seizures and other sorts of brain disturbances and even damage the brain. So when I bring it up and you start being scared, the fluoroquinolones include anything that ends with floxacin. Might sound familiar. Ciprofloxacin, levofloxacin, and there's other ones as well. You don't need to know them about their specifics about them, but floxacins fall into fluoroquinolones. If I ask you what type of drug is a ciprofloxacin, you could choose that it was a fluoroquinolone, or you could choose that it was a DNA or RNA inhibiting. Both of that's true, right? So yes. That's it. You guys like how this is going? Because I do like one freaking slide for these. All right, polymyxins. We mentioned these previously. They affect the cell membranes. This is one of the ones that you see in the triple antibiotic creams, and it's also pretty well used for tuberculosis. So that's really all you need to know is that it affects the cell membranes. But we need membranes too, so it can be toxic to kidneys. And you don't have anything about biofilms on your sheet, but I did want to mention just something about it just for the sake of knowing. Daptomycin inhibits quorum sensing. So that's the ability of the microbes to let each other know how they're doing in the biofilm and, all that. So it'll inhibit that so that it breaks apart the biofilm itself, and you can usually pair it with another antibiotic. But anyways, here's our little breakdown of everything we just talked about and all of that. And that is all that we just talked about and all you would need to know from any of that. Tell me I'm wrong. We had some explanation about it, but if you know that, tetracycline up there is an aminoglycoside, affects protein synthesis, I'm usually not going to ask you about all three at the same time. But hey, if you know tetracycline is an aminoglycoside and you know aminoglycosides affect protein synthesis, that's all you need to know. All right, we got it broken down. So fungal, now going on to everything else. So we already mentioned ciprofloxacin. You guys know Cipro. Now we know Cipro affects DNA or RNA synthesis. And it's pretty commonly used, and it can be toxic to people, but it's very effective as well because more toxic to the bacteria. So my mom, when she was telling me about how she's got this issue with her diverticulitis, she said she was put on 2 antibiotics. Now, we've already gone through all of these antibiotics, and now we're getting into not bacteria. But she told me she was put on ciprofloxacin. Okay, makes sense. Pretty effective. And another one that isn't on our list up there, but it's going to be mentioned in another category. So I'll tell you what it is here in a minute. All right, so fungal infections, not fungal, by the way. Fungal infections, these are essentially, we need to target eukaryotic cells, right? We were targeting bacteria. Bacteria are a whole different thing. Now we've got eukaryotes that we're fighting. And this is pretty much what most of this is, eukaryotes and viruses. They use our machinery, and that's tricky. So they're very similar to our cells, so we have to target them differently. Great, so we have to think about that now because they're eukaryotes. This is all you need to know about the fungal guys. Amphotericin B, azoles, ketoconazole, fluconazole, miconazole, and this other one on the bottom that I don't know anything about, clotrimazole. I don't know about it. But if you, like common fungal infections, you'll be going to the doctor, they'll give you ketoconazole. If you have things like athlete's foot or yeast infections, you're usually going to get fluconazole from your doctor, usually in pill form. And if you go to CVS and you pick up some monostat cream because you think you can handle it yourself with your yeast infection, a lot of those, or at least they used to, they're turning to other ones now, but a lot of those had miconazole, especially like the little external creams that they have that are with it. So you learn about these things affecting fungal infections. So if it ends in, look at that, azoles, man. If they end in azole, they usually are going to be fungal, all right? So azoles and then just rando amphotericin B. I'll say this though, there's one azole we're going to talk about in a little bit that does not affect fungal infections. So there's one. I'll tell you about how I remember it. Remember how we said that about vancomycin, but we don't have to remember that one. Okay, the protozoal and antihelminthic guys. Antimalarial drugs came first. This was originally quinine. If you haven't heard about quinine, you guys have probably heard of tonic water. Tonic water has quinine in it. Usually nowadays, very, very, very tiny amount just for like nostalgia's sake. But back in the day, they used to take quinine in their water in order to prevent malaria whenever the British decided to take over the world and take over India and all these other places that they didn't really necessarily belong. So, but they took tonic water with quinine in it. Quinine was effective at, treating or preventing malaria, but it tasted so bitter. It had a bitter, bitter taste. So in order to make people want to take their quinine and not get malaria and promote that, they came up with this new cheap drink that they mixed in with their tonic water. If you guys don't know where this is going yet, you're going to be so ashamed that you didn't pick it up first. They made this drink, this alcohol drink out of juniper berries, super cheap to make it. And it worked. Everybody wanted to drink their quinine tonic all of a sudden. Gin and tonic. Yep, that's where gin came from. The more you know. I think it's a pretty interesting story. So yeah, that's where gin comes from. And of course now it's, evolved from that, but that's where that came from. Now, quinine causes blindness if you have it in like consistently and in higher concentrations. So we have other drugs that we've developed since then. They're still kind of harsh on us because we're both eukaryotes, us and the protozoa. Malaria are protozoa. So chloroquine and primaquine. So quin on those. So quinine is the original. The ones that came from it, the quins, chloroquine or primaquine. Okay. Then we have the other antiprotozoal and the antihelminthic. So this is what I was talking about, metronidazole. It's an amoebicide and it treats other protozoal infections as well, but it's also very widely used to treat anaerobic bacteria. So this is the one, okay? So my mom was put on ciprofloxacin and metronidazole. And she said that to me and I knew exactly what bacterial infection they thought she had. Clostridium difficile. Because Clostridium is an anaerobic bacteria and it is notoriously difficult to treat. So of course they would be treating it with 2 antibiotics. So that makes sense now, right? Stuff like that. So I was like, she just bring it up to me. I hadn't even gotten to this chapter yet. And I was already thinking about, I was like, oh yeah, I know about this. But yeah, now you guys do too. And stuff like that. So metronidazole, we do prescribe it for anaerobic bacteria pretty widely. And then we have treatment with other protozoans that aren't malaria, basically. The anti-helminthic drugs, we only really mostly hear about these. Of course, we can treat humans with some of this stuff. We mostly hear about this in the veterinary industry. Now here in the United States, that's what we see worms in, right? So praziquantel and ivermectin. Ivermectin will even be in like your like pets, like monthly chews to prevent heartworm. Those little chews that they give them, which my dogs love and will eat it down like crazy, has ivermectin in it so that if you get exposed to heartworms or any other worms in your environment, they can't grow. They're already going to be exposed to ivermectin and will be dead. And it paralyzes the worms and causes them to die from that. But anyways, yes, so I'll treat heartworms with that and everything, if you had it or whatever. The problem is that because their worms are big, right? The worms themselves are, and you can see them. You can see even pictures of dog hearts with the worms all in it and everything. So when you start killing them, where do they go? They don't just like all just instantly reabsorb. So there'll be parts of dead worms floating around their little circulatory system, and they have to like have their bodies process that. So what they do is they'll give you like a couple high doses of ivermectin, and then your dog, well, not you, but your dog, and then your dog has to be like locked up and can't move essentially for 4 to 6 weeks, sometimes up to 8 weeks, depending. So that's just to let their body kind of reabsorb or get rid of the worm parts that way, as opposed to it getting clogged in their arteries and causing embolisms, which is what they're really worried about. That's why you can't run around, because it will cause the pieces to get stuck in the arteries. So this is Spaghetti and Meatball. We adopted them knowing that they had heartworms. And so, you know, we had them for a month when we first adopted them. And then we went through treatments that had some, you know, familiar people, somewhere to come that was actually home and everything like that. And then they had to stay in their little crates. They only got to come out to go potty, and they made it. They're doing good. They got the all clear right after the treatment. They were good. And then we had them checked again 6 months later, and they're still clear. So they're nice and happy. So it's Spaghetti and Meatball. They're my little boys. And the only way you know the difference, they're both little black dogs, but Meatball's got the little tuxedo. He's got a little white on his chest and the little white paws. And if you look closely, you can see the little spaghetti sticks. I think they're so cute. They're cute little boys. All right. Also annoying at the same time. Just like all dogs. All right. Antivirals. This is the problem with viruses, is that they're using your machinery. So we have to target things that are specific about viruses, and every virus is kind of different. So a lot of times antivirals will treat like a specific group of viruses. So to say, for example, when you go have the flu and you're given like Tamiflu, that doesn't treat any other viral infection. You know, it's sort of like that. So there's only 2 antivirals that you'll have to know about, but these are the way that they target. They either stop from getting in, prevent them from building their parts, or stop them from leaving, from budding out or something like that. So first, the entry ones, this will include Tamiflu and Relenza. They do the same thing. There's an enzyme that is found on the surface of flu viruses that it uses to get in, as well as to help bud out. So if we can block that, then it helps it from doing either of those things. And that's what those drugs will do. So it's that enzyme is called neuraminidase. So when you guys hear H1N1, the N is neuraminidase. So as you can tell, those are very important proteins for those guys. So the Tamiflu and Relenza. Then we have the nucleic acid synthesis inhibitors. I don't know why it's not on the slide. I have no idea why it's not on the slide, but it is on your study sheet, and I do think you need to know it. I had it originally on the slide. I just don't know what happened to it. I must have deleted the wrong slide or something. But anyways, acyclovir. Acyclovir is an antiviral that blocks DNA or nucleic acid synthesis, and typically herpes viruses. They can be used for other viral infections as well, but acyclovir treats herpes. But if I call it valcyclovir, which is another version of it, valcyclovir or Valtrex, you guys probably heard of that one. So, and you can get that same antiviral incorporated into like an ointment that you can put on cold sores that they call Abreva. So that's that one. It's pretty effective for that. So that's acyclovir. And then we also have the HIVs that I didn't really talk too much about, but you want to target things that are specific to them, like protease, integrase, and reverse transcriptase. But I don't know, whatever. They have more targets. But it's just hard to get rid of them because they incorporate into your DNA. So how do you get rid of that? All right, drug resistance. You can be intrinsically resistant or you can acquire your resistance. So intrinsic means like intrinsic, you intrinsically are able to do this thing or whatever. That means we're able to do it from the get-go. So if you're a bacteria that makes streptomycin antibiotic as part of like your defense against the guys around you, you better be resistant to streptomycin, obviously. You'd have to, or otherwise you're killing yourself. So it makes no sense. But yeah, you have to be resistant to what you are making. The acquired one is the obvious one. You get it from other bacteria. You didn't have it and now you've got it. What's that? Okay. Yes. So we're kind of going to talk about that in a little bit. I'm not in a whole lot of detail, but there's something to be very concerned about with that. I do have a video on Canvas. And what I mean by on Canvas, there's videos on, like when you guys, if you go to the modules and at the very top part, it will have like chapter 12, the very first chapter 12 link. It goes to like some words and there's like videos all in there. It's for my online students more than anything. It gives them a rundown, has lecture, but then it also has like a rundown of the stuff. There's a video in there of the E. coli, that's plain old E. coli, becoming more and more resistant to an antibiotic just randomly on random mutations. It's terrifying to think about. It takes like 48 hours maybe. Which is the amount of time that your stuff goes in the incubator. So think about that. There is very minimal chance that you'll have a random mutation, what we call spontaneous mutation, that's going to be advantageous in any way. But think of how many times bacteria are going to be dividing. Like if you go from one cell to billions in a matter of like overnight, and there's a 1 in a million chance that this, one mutation will help. Well, then already you've got 10, 100, whatever, 1,000. Yeah, 1,000 guys that have a helpful mutation. Don't ask me to do math. If I did that to myself, I guess. So, but yeah. So yeah, at some point, it's like what they tell you about like the planets having life. You're like, oh, there's only a 1 in a billion chance there's a planet with life. And then you do the math of how many planets there would be in the universe. And it's well beyond a billion. I mean, we're talking well beyond a quadrillion planets out there. Kind of gets you thinking about how much you want to think about that stuff. Maybe don't think about that stuff because it's kind of terrifying. But that's what's going on here. You say it's unlikely, but if you divide enough, it's going to happen. And so it does. And so the ones that are able to survive that situation go on and reproduce. We also have horizontal gene transfer. If you guys need me to explain this again, I don't know what to tell you. Transformation, picking up exogenous DNA. Transduction, bacteriophages putting their DNA into the bacteria. Lysogenic conversion, right? Conjugation, that's the sex pili, so transferring things in between a little tunnel between cells. This could be plasmids that are doing that. Usually it's going to be plasmids or it could be bits of the DNA. But we also have something called transposons, which are just genes that can jump from that plasmid into another plasmid or from that plasmid into a chromosome and become like incorporated in. So those are transposons. We mostly see this happening in bacteria and sometimes plants can do that. And that's what the issue is sometimes with genetic engineering on those guys. But anyways, we don't see, you would of course rely on the spontaneous mutations just to happen randomly, but this stuff happens very frequently in nature, just transferring between the bacteria. Even your own biome can have a part to play in all that. With drug resistance, there's a few ways, I think 5 different ways we have that you can be resistant, and I'm just going to give you summaries of them. You can have enzymes that like break down the drug and inactivate it. Genes would enable you to make those enzymes. You could be able to stop the drug from getting in altogether. You could eliminate the drug if it does get in. So they have little like pores that they can like shoot, the drug gets in, and you just shoot it back out right away. That's a thing. Then we have less access points. So all the points that the drug could have got in, we just have less of them. And then we have changing metabolic pathways like we talked about with the folic acid. The bacteria, when we block that pathway, the bacteria will just find another way to make it. Not like it just chooses, but some of them evolve. They get mutations that help with that, or they pick up mutations that help with that. This is just showing an example of how obviously if you just have like somebody that is resistant, like the red cells here, and you treat it with an antibiotic, all you need is like 1 or 2 cells that survive. And now the whole population that's grown back up afterwards is resistant. And you can also spread that gene to another cell. What humans have done to play a role in all of this, 75% of basically antimicrobial prescriptions that are made for humans are for throat, sinus, lung, and upper respiratory infections. And grand majority of those are viral. And doctors just aren't looking to check. And so they're just going to give you an antibiotic just to be safe. So if you've ever gone to the doctor and, had a cold or something and they gave you an antibiotic, it's because they're lazy and they're part of the problem. We had the shotgun approach, which is just like essentially throwing either high concentrations or more than one antibiotic just to cover their butts. So that can be a problem leading to resistance. You're just exposing more bacteria to more antibiotic. And then we have the fact that we export our antibiotics out to other countries and they are not using it responsibly and they lead to resistance and that comes back to us. Right, hospitals also play a part. You have weak patients who are sick. They're more likely to be infected and they're probably also already on antibiotics. And it gives it like a breeding ground essentially to be resistant. And you also have poor hygiene or PPE practice that can be an issue. It doesn't have to be a lot of people, but you just forget to wash your hands once or you forget to change your gloves once and you spread something. Now we have today, it says up here nearly 100% and it's quite very, very close to 100% of all staphylococcus in the entire world. Not talking about hospitals, I'm talking the whole world, everywhere you go, 100% of it almost is now resistant to penicillin, the first antibiotic. Not all of it's MRSA, but it's all resistant to something. That is terrifying because it wasn't born that way originally. Then we have animal feeds. Now read this with me and really think about what I'm saying here. Nearly 80% of all antibiotics in the United States are given to livestock. They're not sick. They're not when they give them these antibiotics. They're not sick. They're just giving it to them because it helps them make better, higher quality meat. And so that is kind of gross to me. And it should be to you too. That's unnecessary to have that much of our antibiotics going into that system, creating resistant bacteria in the livestock industry that can be essentially transferring their genes back to humanity, which is, it happens. Unnecessary. So we know about that we're probably entering anyways, a post-antibiotic era. If you haven't been paying attention, increasingly we have more and more species of bacteria that are completely resistant to all existing antibiotics. All of them. So here are some concerns. These are the top ones. If you are resistant to carbapenem, we've got a real problem here. So we've got issues with Acinetobacter, Candida auris, which is similar to Candida albicans, which is the normal one we think about with yeast infections. We see Candida auris a lot in immune compromised people, or on like Humira and stuff like that. And then they get that, and then it's hard for it to be treated now. I mean, look at it's in the urgent threat category. C. diff, not surprising. Enterobacteriales, these are gram-negative gut bacteria that will be carbapenem resistant. And then we have drug-resistant Neisseria gonorrhea. What kind of drugs? All. We have this is not uncommon. It's not like some random, there's a strain out there somewhere. It's increasingly being seen more and more and more. And it is the #1 strain seen in, I believe, Japan, completely resistant to all drugs, gonorrhea. What do? So you go to the doctor and you've got gonorrhea. And they're like, yep, you have gonorrhea. It's completely resistant to everything. And they're like, okay, so what's the treatment plan? The treatment plan is you go home and use condoms. That's it. You get to have gonorrhea forever. Imagine that. They can't treat it. There's no getting rid of it. And we're so used to it. Okay, we'll give them another. Nope, there are none left. There is nothing we can do. That's where we are. This should be terrifying to everybody in here. That is the worst of them here. MRSA is down in the next one. It's not even in the worst of them. MRSA is nothing compared to those. Believe me. Those top ones are terrifying to any infectious disease control person ever. So anyways, we got a bunch on here if you're interested in looking at them. It's a huge, huge problem. So what do? We can find new drugs or, make custom designer drugs, but aren't they just going to become resistant to those too? Yes. So what do we do then? Use different things. Nanomaterials, antisense RNAs, CRISPR, use bacteriophages to shuttle things in for us that can target specific bacteria. And then, antibiotics that might just only target certain aspects of gram-negative surfaces or something, but all of them. So it's not yet. They're just trying to say that could be a way that we could potentially use it if we could get there. So these are not happening. This is not useful yet. None of those bottom ones are. It's just stuff that we're trying to work towards to replace antibiotics. But for now, what we can do to support our biome and support our bodies and make them healthier. Probiotics are actually good. They do actually work. If you're one of those people that's like, okay, whatever, probiotics, what a fad. Nope, they're actually really good for you. They do really work. They help replace any lost microbes that you had if you did take antibiotics. That's why they tell you to have yogurt after you've completed your antibiotics. And they can supplement your existing biota. It made a huge difference for me as far as how my gut functions, because I wouldn't, it was a big deal. And then we have prebiotics that just help feed the good guys. So you usually want both of them if you can get them. And then of course, helping nature along, it says fecal transplants. It sounds awful, I know. But if, for example, my mom with her thing, they could really give her high concentration antibiotics and just clear out her whole biome of her gut. And then under anesthesia, she'd be unconscious, and through a colonoscopy, they would have a slurry of feces from my dad, probably, because that's who she's closest with in her life. And she probably has a pretty similar biome, and replace her biome with that by putting it in there via colonoscopy. This can help actually drastically improve people's lives who are dealing with these infections like C. diff or something like that. Yeah. Still need a biome. So this was my page that I made after talking through all that. It's a lot of terms and explanations, but this is how I organize all of those areas together. I just copied and pasted all of it. And you guys can definitely pare it down to just things that you would need to use if you were making your own, but also, hey, all the information is there. So that was my study sheet for this one. And that's how, that's what I would make after the class, right? Reorganize my notes and make sure everything made sense into one sheet, so that whenever you're ready to study, you can just look through this. And if you saw it saying I don't know, something like selective toxicity, kill microbe without hurting us, then you might be like, hey, what does that mean? And go back to that, of course. But I think it saves time, personally. Good. That's it for this chapter. We're going to go take this lab exam. You guys take your time getting up there. You do need your lab coats, but I have to go set up, obviously turn on some of the microscopes and things like that. Can't just leave them on.